Welcome to This Explainer. Let's get right into it. Today, we're taking a completely exhaustive, step-by-step look at L1 syndromes and pediatric arrested hydrocephalus. If you're looking for that deep dive where absolutely zero textbook details are left behind, well, you're in the right place. We're going to break down the subtle radiologic clues, the exact genetic markers, and the hard and fast neurosurgical rules you need to know.
Here's our agenda for today. First, L1 syndromes, the basics. Then, severe L1 and radiology. Third, L1 syndrome treatment options. Fourth, arrested hydrocephalus defined. Then we hit the shunt independence debate. And finally, managing non-functioning shunts. Let's jump in.
Section 1. L1 syndromes, the basics.
Okay, so L1 syndromes, they aren't just one single presentation. They're actually a whole spectrum of diseases. The big ones to keep in mind are X-linked agenesis of the corpus callosum, or ACC, and spastic paraparesis type 1. The crucial takeaway right off the bat is that we are dealing with a specific spectrum of X-linked neurological conditions. That genetic inheritance pattern, it is absolutely vital to how we screen and counsel patients. Historically, medicine has categorized the spectrum using some pretty distinct acronyms. You've probably heard of CRASH. That stands for corpus callosum hypoplasia, retardation, adducted or clasped thumbs, spastic paralysis, and hydrocephalus. Then we have MASA, which is mental handicap, aphasia, shuffling gait, and adducted thumbs. And lastly, HSAS, or hydrocephalus with stenosis of the aqueduct of Sylvius. Now notice the overlap here. Things like adducted thumbs keep popping up across the board, giving us a really tangible physical sign to look for during an infant exam.
This whole spectrum feeds directly into clinical staging, which basically splits into mild and severe categories. Mild L1 is going to feature those adducted thumbs, the spastic paralysis, and the hypoplasia of the corpus callosum. But then look at the severe criteria. It's all those mild features plus this huge cascade of structural brain anomalies. We're talking anterior cerebellar vermis hypoplasia, a large massa intermedia, an enlarged quadrigeminal plate, and a really specific post-shunt finding we'll get into in a second. Bottom line here, virtually all severe cases present with profound mental retardation, so making that distinction between mild and severe, it's absolutely critical for predicting the patient's prognosis.
Moving on to Section 2, severe L1 and radiology.
When you're looking at an MRI for severe L1, there are 6 specific radiographic findings you've got to systematically check off. First, check the posterior region for severe symmetric hydrocephalus with predominant posterior horn dilation. Next, look right in the center for a hypoplastic or completely absent corpus callosum. Third, keep an eye out for a hypoplastic anterior cerebellar vermis. Number 4, check the midline. You're looking for a large massa intermedia. Fifth, scan near the brainstem for a large quadrigeminal plate. And number 6, this is a highly unique post-surgical finding, a rippled ventricular wall following a VP shunt placement. These exact structural abnormalities are what define the severe form.
And that final radiographic finding brings us to a massive diagnostic rule. A rippled ventricular wall following a BP shunt placement is pathognomonic for X-linked hydrocephalus. Now, in medicine, pathognomonic is a heavy word, right? It means if you see this one specific sign, it's an absolute, definitive diagnostic marker. It literally leaves zero doubt about the X-linked nature of the hydrocephalus.
All right, Section 3, L1 syndrome treatment options.
Our source material breaks this down into a really systematic 4-step management protocol. Step 1 is placing a VP shunt. But, and this is a big but, we have to acknowledge the harsh reality here. The shunt's main purpose is managing head size to make things easier for the caregiver. It does not, I repeat, does not improve the neurologic outcome or the retardation status. Step 2 is simply acknowledging that right now, no genetic therapies exist for L1 CAM protein abnormalities. Step 3 shifts to prevention and planning, meaning early prenatal ultrasounds around 20 to 24 weeks with frequent repeats for known carrier mothers. And finally, Step 4. Male infants who present with hydrocephalus plus at least 2 of the clinical or radiographic signs we talked about, they absolutely need genetic testing for the L1 CAM mutation to help with future pregnancy counseling.
Which brings us to Section 4, arrested hydrocephalus defined. So you'll often hear the medical community use the terms arrested hydrocephalus and compensated hydrocephalus interchangeably. What this refers to is a really specific situation where there's no progression and no deleterious sequelae from the hydrocephalus that would actually require a CSF shunt. Basically, it's like the patient's body has figured out a workaround and found a natural equilibrium all on its own.
But to truly classify hydrocephalus as arrested in an unshunted patient, 3 exact criteria have to be met simultaneously. It's a delicate balance. First, the imaging needs to show near normal ventricular size. Second, the growth charts have to track a totally normal head growth curve. And third, all the developmental milestones have to line up, showing continued psychomotor development. If a patient misses even a single one of these markers, you just can't safely call it arrested.
And even when a patient hits all three criteria, we can't just walk away. We have to be incredibly vigilant for decompensation. Families absolutely must be counseled to seek immediate medical attention if they see any signs of intracranial hypertension. We're talking sudden headaches, unexplained vomiting, ataxia, or any visual symptoms. Like I said, the balance of arrested hydrocephalus is really delicate, and catching a sudden decompensation early is literally a matter of life and death.
All right, Section 5, the shunt independence debate. Now, the whole idea of a patient becoming independent of their shunt, it's definitely not universally accepted. Basically, there are two main camps here. Perspective 1 suggests that shunt independence is way more common when the hydrocephalus is caused by a block at the level of the arachnoid granulations, what we know as communicating hydrocephalus. But Perspective 2 argues differently, pointing to experts who've shown that shunt independence can actually happen regardless of the underlying etiology. So yeah, it's still a heavily debated topic among neurosurgeons.
And you really see the gravity of this debate when you dive into the clinical literature. Our source gives this very stark warning. These patients must be followed closely, as there are reports of death as late as 5 years after apparent shunt independence, sometimes without warning. That's a sobering reality. It drives home exactly why slapping the label independent on a patient does not mean they are cured. They still need relentless, ongoing monitoring.
Finally, Section 6, managing non-functioning shunts.
Okay, before you even consider removing a broken shunt, you have to understand this wild anatomical loophole. A disconnected shunt might actually still be doing its job. How is that possible? Well, it allows cerebrospinal fluid to flow through what's called an endothelialized subcutaneous tract. The body literally builds its own biological tunnel right around the hardware. So even if the mechanical tubing snaps or separates, the fluid is still finding a path to drain.
Because of that hidden biological workaround, the source material gives us the absolute golden rule of pediatric neurosurgery. When in doubt, shunt. This is the ultimate guiding philosophy when you're caught deciding whether to repair or just remove a questionable shunt.
Actually, there are 4 absolute indications that demand you repair a broken shunt rather than pulling it out. 1, if the shunt is even marginally functioning, you keep it. 2, if there's any presence of increased intracranial pressure signs, think vomiting, an upgaze palsy, or sometimes just a severe headache alone. 3, any clear changes in cognitive function, decreased attention span, or noticeable emotional shifts. And 4, if the patient has underlying conditions like aqueductal stenosis or spina bifida, because the vast majority of those patients are strictly shunt dependent. In every single one of these scenarios, you repair, you do not remove.
Elective removal is incredibly risky. In fact, surgery for the sole purpose of removal should really only happen in the case of a shunt infection, and even then, you're usually placing an external ventricular drain, or EVD, in the meantime. If a patient is left with a non-functioning shunt, they have to be followed super closely. This means a strict protocol of serial CT scans and often serial neuropsychological evaluations just to ensure they aren't silently decompensating under the radar.
We've covered a massive amount of ground in this explainer, from the pathonomic rippled ventricular walls of severe L1 syndrome to the really perilous realities of shunt independence. So I'm going to leave you with this final, provocative thought. As we continue uncovering subtle radiographic clues and mapping out these complex genetic markers, how will the inevitable arrival of future genetic therapies ultimately challenge, or maybe even completely erase, the absolute neurosurgical rule of when in doubt, shunt? Something to think about. Thanks for joining me today, and keep questioning the textbooks.